It is, I'm sorry, it's only 3:59, so we have a few more seconds until we go ahead and get started. I just wanted to welcome everybody. It's been a busy day, so I've been multitasking up until the final minute. And we have 4 o'clock here on the East Coast, so I'm going to go ahead and get started. Welcome, everyone. I'm glad to have you here with me this afternoon. See, I'm going to make that mistake several times today, calling it this evening. But I'm very glad to have you here with me this afternoon. I think that hopefully some of you have attended the first session last week. If you didn't attend the first session last week, I'm going to do a little recap in the beginning. So for those of you who were here, I'm really sorry, but you're going to have to sit through a few slides that you probably have already seen. So I just ask for your patience with that and feel free to contribute. But for those of you who did not attend, it'll be a little bit of new information so that we can just kind of ground ourselves in this idea and topic of sexual health. The other thing that I just want to say is I'm experiencing some lung issues today because of the wildfire smoke that we have here on the East Coast. So I may have to pause and mute myself and cough and kind of come back to it, but I just wanted to let you know that beforehand. So if you hear me wheezing or struggling or anything, I am okay. Just a little bit of smoke that I'm dealing with today and yesterday and the day before. And I think all of you on the West Coast understand wildfires a little bit better than we do here on the East Coast because it's not something that we typically have to deal with, but here we are. So welcome everyone, and let's go ahead and get started. So today we're going to be talking about some additional issues that we didn't cover last week around sexual health. We're going to talk a bit about gender identity, affectional status, which in the past was typically just solely referred to as sexual orientation. And we'll talk a little bit about why there's a change in the language around sexual orientation to affectional status. Excuse me. And we will also kind of dive into how to use a technique like motivational interviewing as a framework to have discussions with the individuals that you're working with around sexual health. And obviously you can use the technique of motivational interviewing as a counseling technique for other issues, but it is extremely effective and helpful using that framework when discussing challenging topics. So we'll get into that. And there's also going to be some resources at the end that I'm going to provide you that includes a toolkit for actually, having these discussions with individuals specifically around sexual health. And it was a toolkit that was designed by one of my mentors, and I think that it's really helpful. So like every other webinar, we have to go through some of the housekeeping. So I want to welcome you. Today's webinar is being hosted by DBHR through the Healthcare Authority. This is an interactive training, and we encourage you to ask questions and interact throughout this session. The slides, as well as a link to the recording of this webinar, will be available in the follow-up email after the presentation. So you'll probably get that email tomorrow or Monday. So just to let you know, because of webinar settings, everybody's currently muted, but if you would like to talk on the microphone instead of typing comments out or typing out questions, you can feel free just to say, I'd like the mic, and I will definitely give you the mic. If you've ever attended a webinar with me before, you know that I love conversation and I love discussion. I think that, I know that I still have a lot to learn. And so I love that dialogue because it gives me ideas and thoughts and information that I hadn't considered before. So, and I just think it makes the session a bit more dynamic, and you're not just sitting here listening to me drone on for an hour plus. So feel free to type in any questions or ask for the microphone as questions arise. This is a little bit about me when I was a different me with different hair color and different glasses. But so I've been with Rutgers since 2014. And before that, I worked 17 years in supportive housing. as a case manager, supervisor, then program director, and also with Homeless Street Outreach called the PATH program. And in addition, I've done a lot of disaster response crisis counseling work. And that has been probably the most rewarding part of my career. Because we all like to be a hero, right? But it's also taught me a lot about resilience and trauma. And I think it's a very valuable experience. So for this webinar, some of the things that I'm hoping is that you'll be able to define sexual health. That will be a review or recap from part 1. So if you didn't attend part 1, you'll get some of that today. We're going to talk a little bit about intersectionality, which we did discuss in part 1. So we're just going to kind of like recap that a little bit as we move forward, because we're going to be, hi Kimberly, because we are going to be having a discussion about terminologies and groups of individuals who are more likely to be oppressed and stigmatized. In addition, on top of a diagnosis of a psychiatric condition, which we already know can be stigmatizing. I'm going to differentiate and define gender and affectional orientation. Again, what we used to refer to as sexual orientation. Both terms are still used, but I just want to introduce this newer terminology if you haven't already heard it. And we're going to look at strategies for supporting individuals in their sexual health journey. And again, that's where we're going to pull in the use of motivational interviewing to kind of support those sometimes difficult discussions. Okay. So for those of you who were with me last week, one of the things that I asked folks were, what are the things that you think of the benefits of a positive, romantic, or intimate relationship? These were some of the things that came to my mind. You know, for me, without love, I don't really see the reason for a relationship. But that's me. And there's many different types of relationships out there and ways that people feel fulfilled in relationships with other people. For me, also, having a person that offers me support and that I can offer support is really reassuring to me, right? Like, not that you want to become dependent on a person, and I'm not talking about this like toxic idea of codependency or anything like that. But when I talk about support, you know, I just mean like, you know, sharing in each other's struggles and supporting each other in goals, right? And maybe even having some shared common goals. And also this idea of growth, right? That like two people coming together, you know, hopefully it's a relationship that supports the growth of each other, and that it doesn't feel good to be in relationships where one individual stifles another, or that their needs aren't as important as the other. So this idea of mutual growth to me is really important to me. And so for me to have a fulfilling relationship, these elements really are, you know, they need to be included. So I'm curious from all of you, like, what are some of the things that you think of when you think about a positive romantic relationship? Those like positive side effects that you may incur as a consequence of being in that relationship. So you can go ahead and type it in the chat, or if you'd like the mic, please feel free, and I will be happy to turn your microphone on. So we'll just pause there for a few seconds, maybe 15. Okay, I see the chat box. Yeah, confidence, so confiding in. Yeah, isn't it nice when you have, whether it's a really good friend or hopefully your romantic partner is also a really good friend, but that ability to be able to share things with people that you may never have thought of sharing with another person before, right? That ability to be vulnerable and to tell them, you know, these are the things that kind of scare me or the things that excite me. Yeah, mutual goals, the ability to allow oneself to be vulnerable within the relationship. That's huge. And that could also contribute to growth, right? I mean, sometimes we're vulnerable in a relationship. And even if things don't go out as we had anticipated, even if the relationship ends, I feel that if we learn something in that process, then that leads to growth, right? But that can only come with being somewhat vulnerable. Sarah says the good things, the really fun things, chemistry. Absolutely, we love chemistry. Fun, laughter, being a cheerleader for each other, and so much more. Absolutely. And Heather says mutual support, enjoying one another's company. Yeah, so I think that those things are all forms of what's up here on this slide, right? So enjoying each other, supporting each other, sharing common goals, growing with each other. And one of the things that we discussed last week that can be really challenging with people, for people with psychiatric conditions and other potentially disabling conditions or conditions that people may have, you know, chronically, is this like being indecisive about how much we share with a person, especially at the start of a relationship. So one of the things that people with psychiatric conditions have said is that, you know, it's sometimes a real struggle determining how much you want to disclose about a situation or a condition that you have or that you live with, that you manage on a day-to-day basis, and one that could potentially affect the health of the relationship. So for instance, if a person has depression and they know that sometimes they may isolate when they're having a difficult time, when they're struggling with some of their symptoms, or maybe when their stress level increases, they may isolate, they may pull back. Well, if that discussion isn't had with a romantic partner, that can really send scary signals to that other person, right? If you're experiencing an exacerbation of those depressive symptoms, and you start to do what you maybe normally do, which might be to retreat a little bit, to isolate a little bit. And that's not to say that there's anything necessarily wrong with that. Sometimes people need kind of a time out and need to pull in a little bit and, you know, kind of evaluate things. But without being clear, without confiding in that other person, it could really just kind of leave them feeling like they don't know what's going on, that maybe you've pulled away because you've met somebody else or whatever. So this idea that you can find somebody that you can confide in and let them in on your own challenges is really, really reassuring to people once they find someone that they can have that kind of connection with. You know, one of the stories that I like to tell is that, you know, when I was previously married, and when I was married, one of the things that I did was I had to disclose. I felt I really, you know, needed to disclose before my husband and I got married that I lived with depression and that I lived with an anxiety disorder. And at times when it's not going so well, this is what it looks like, and be on the lookout for those kinds of behaviors or signs or symptoms. And I specifically had to tell him what things he could do that could be helpful to me and what things not to do. Like, don't tell me to get over it. Don't tell me to calm down, right? Those kinds of things that aren't real, or to cheer up. Those things aren't so helpful. So also in disclosing to a partner or even to a friend, you know, what that looks like for you or for an individual, and what you need during those times of difficulty is so important. And it could in the future like really enrich the relationship. So I thank you all for sharing. I really appreciate that. Okay, so let's just take a step back and review what it is that we mean when we say sexual health. So again, for those of you from last week, this is a little bit of a recap, but the World Health Organization defines sexual health as to being fundamental to the overall health and well-being of individuals, couples, and families, and to the social and economic development of communities and countries. And so sometimes when we think about sexual health, we think about like the disease prevention, or we think about, you know, reproductive care, or we think about sexual pleasure and arousal. And we sometimes think of these things as like kind of distinct notions, but it's all a part, distinct concept, but this is all a part of the global definition of sexual health. And as you see here, one of the things that it says is that it's crucial to the development of communities and countries. Why do you think that that might be? That the overall sexual health of a population of people is an integral part to the overall health of a nation, of a country, of a community. Why would that be? Why do you think that that would be? And if there's no answers, that's okay, because I can give it to you. So one of the reasons is because that we know that, and I see a chat bubble. So Casey said self-actualization seems to go with this, which is on the hierarchy of needs. Sure, absolutely. And Sarah said, of course, population growth and to sustain country and community. Absolutely. So, when we think about and also things like when we consider intimate partner violence, things like, it doesn't happen often, thankfully, in this country. But in other countries, things like female genital mutilation and other kind of practices that harm a population, you may be taking what could be in the future healthy working individuals and healthy community members out of the population, right? And so there are things that we need to be aware of, or this concept of sexual health. We need to be aware that it is just as important as any other facet of physical or mental health, because it does directly contribute to the health of communities. And being sexually healthy requires a positive and respectful approach to sexuality and sexual relations, not just for the person, but for the individuals that the person is receiving services from. So this idea that we respect an individual's sexuality, an individual's gender identity, as well as the possibility of them actually, having a pleasurable sexual part of their life, right? So this ability for them to be able to be in sexual relationships, if they so choose, to a satisfying level, that it should be free of violence, that it should be free of coercion, that, as much as possible, we want to support them so that it's free of dysfunction. We know that a lot of medications that individuals are prescribed, not just for psychiatric reasons, but for other health conditions such as blood pressure, other cardiac issues, these kinds of medications can have a direct negative impact on an individual's ability to become aroused, to become sexually aroused, to even experience a sense of desire, or what we call libido, and the ability to actually, complete the sexual act to satisfaction. So it's really important that we're able to develop comfort around talking about sexual health with individuals so that we can ensure that they're having the most satisfactory sexual life and sexual activity as they can have. Because one of the things that we do know is that individuals frequently stop taking psychiatric medications and probably other medications, but we kind of live in the world of psychiatric services, so that's what we're going to concentrate on. When individuals stop taking medications, one of their chief complaints is that it was because the medication caused sexual dysfunction. That is when they're being honest. Sometimes very often people will stop taking medications without providing that reason, because we're not a very open society that welcomes having these conversations. And so that's, my primary goal for doing this series is just to get us a little bit more comfortable having those conversations, not just because we want people to be sexually healthy and we want to support that, but also it does, dissatisfaction in one's sexual health domain or aspect of their life can contribute to difficulties in other areas. So if an individual says, my doctor prescribed this medication, and now I'm experiencing erectile dysfunction, or I cannot reach orgasm, and now I don't have a fulfilling relationship with my partner or partners, that could very much contribute to an individual deciding to stop taking their medication, especially if they don't feel as if they can have that conversation with their prescriber or anybody else kind of within their support system. And so, really encouraging people to be able to have these conversations with their prescribers and to say, this isn't working so well for me. Can we look at the dosage, or could we look at taking this at a different time of day? Or is there a different medication I can switch to? These are really important conversations to have. And in fact, there are two big reasons why psychiatric prescribers, and this research comes out of Europe because there's not a whole lot of this research that happens in the United States because of our historically sexually repressive culture. But one of the things that psychiatric prescribers say in the research that comes out of Europe is that when they choose not to tell somebody about sexual side effects, it is because they're afraid the person will reject the medication. And unfortunately, without preparing an individual and saying, this is a possible side effect, we don't know if it's going to happen with you, but please let us know right away if it does happen, because there are things that we can do to lessen that negative side effect. You might be able to prescribe something else to help you with that, like a Viagra or Cialis or something like that. We might be able to lessen the dosage or change when it's administered. These are conversations that staff need to be proactive in and not wait for our clients or consumers or participants to come to us with the problems. So today, excuse me, today we're going to talk, as I said earlier, about gender identity. Really, we're not going to get super deep into it. I'm really going to go through some terminology, some definitions, and these may be things that you already know. And if you can contribute to the conversation, I would absolutely welcome you to do that and to augment the lesson. And we're also going to be talking about affectional or sexual orientation. So these have historically, been in addition to the label or the diagnosis of somebody having a mental illness or a psychiatric condition or a substance dependence. Gender identity and sexual orientation have unfortunately, and still to this day, been areas where people have been stigmatized and faced discrimination. And so if you remember last week, if you were with me, we kind of talked about stigma and how does this result of stereotyping and creating divisions and this low kind of like status in terms of people being less desirable or being in the out group, right? And unfortunately, as human beings, we've done this a lot throughout history. I know none of you have done it, but we have done this collectively as human beings a lot throughout history, created different groups, right? And there's always this out group and an in group. And it leads to discrimination and labeling, and it's this vicious cycle that continues to perpetuate itself and kind of support itself as this like self-sustaining phenomena if we don't interrupt it with education and exposure to people in different groups and learning. So what I need you to understand, and I'm sure that you already do, is that when we're talking about intersectionality, we're talking about that intersection, that literally coming together of these multiple characteristics, that his personal characteristics about an individual or group of individuals that historically those personal characteristics have drawn discrimination, have drawn stigma, have turned into labels. And people have been viewed as, in the case of people with psychiatric conditions, very often they've been perceived as violent or perceived as flawed in some way, as if having a mental illness, having a psychiatric condition, or having a substance use disorder is somehow, a moral deficit. And so, when you also consider that there are individuals from other marginalized groups, whether it be based on race, religion, ethnicity, national origin, sexual orientation, or gender identity. There are these other groups that have also been oppressed. And so there's this layering on effect of stigma that really reinforces an individual's negative self-thoughts of, I'm not good enough, somehow I'm flawed and I don't fit in. And all of this comes from those external messages that, if not interrupted by good folks like you and people in the person's support network, can really do a lot of damage. In one study that I participated in, and it was a work-related study with individuals who were recipients of assertive community treatment. So in New Jersey, we call that PACT, but it's a national comprehensive targeted kind of case management approach to individuals who are at risk or have been psychiatrically hospitalized. One of our findings was that it was a person's illness identity, their adoption of their illness as a reflection of their self, that kept them out of the workforce, and not their psychiatric symptoms. So the amount of psychiatric symptoms that the person may have experienced, that wasn't the thing that was keeping them from working. It was them thinking of themselves as flawed, as incapable, all of these things, all of these messages that have been sent to them. So we really kind of want to intervene there, because we know how devastating that can be to a person's self-agency, confidence, and so on. So when we talk about achieving sexual health, we really need to think about, sorry, I just need to move my camera, little bubble. We really need to think about these four main areas, and those are having access to comprehensive, good quality information about sex and sexuality. So I want you to think about like the age at which a lot of psychiatric conditions can kind of emerge. For a lot of individuals, that happens in their late teens or in their 20s. So it's typically like that 18 to about 30-ish age range, usually a little bit earlier than 30, but that kind of like 18 to late 20s age range. Sometimes for women, it can happen at childbirth because of change in hormones and stress on the body, trauma. So it could happen later for some individuals. It could also occur later in some individuals because of the experience of trauma. But for those mental health conditions that we think about that are like the big three in terms of potentially disabling conditions, which would be bipolar disorder, the schizophrenia spectrum of disorders, so like schizophrenia and schizoaffective disorder, and major depression, especially recurrent depression, a lot of people experience these initial onsets during those years when we're like figuring out what sex is all about, when we're figuring out what relationships are all about, when we're exploring our likes and our dislikes in partners and in sexual activity, and when we're learning about sexual health, period. And so sorry, I have a little fruit fly. And so we cannot take it for granted that the individuals that we're serving already have this information, because they may have absolutely missed out on it as a consequence of their psychiatric condition, right? Also, we need to remember that when individuals have psychiatric conditions, when they have the onset of a serious mental health condition, they may lose skills or knowledge that they've acquired due to institutionalization, due to experiencing homelessness, and just due to some of the degradation of like cognitive faculties and things that can occur, while somebody is experiencing a psychiatric condition. And so it's really important that we're able to be available. If we're not teaching them, that's okay, but to be able to recognize when people have needs that are unmet, and to be able to, adequately link individuals to that information or services that they need. We definitely want people to have knowledge about the risks that are faced and vulnerability to certain consequences of unprotected sexual activity. I cannot tell you how many times I've heard people, even in my own peer group, and I'm almost 50 years old, in my own peer group, talk about things like HIV as if it's really not around anymore, right? And I say, yeah, HIV is something really important to worry about, but at the same time, so is HPV because it can lead to cancer. And at the same time, so is chlamydia and other conditions. And there are certain conditions that may be a little bit more insidious and people may not realize that they have conditions, and ultimately it can affect their ability to have children if they want to have children. It can affect them systemically as well, and lead to things like cancers. And so we really do want to make sure that people understand, not only what it means to be safer when having sexual experiences and interactions, but also where they can go to acquire the things that they need to be safe. Ability to access sexual health care. And so this may mean, making individuals aware of, we used to call them family planning services. I like to just call them sexual health services now. But, helping them understand the role of sexual health care. I don't know about any of you, but I've worked with a lot of women in my career as participants of supportive housing or participants in the PATH program who had never seen a gynecologist in their life, and they were in their 30s or 40s, who had never had a pelvic examination. Men who have never, been evaluated for testicular cancer, prostate cancer, right? And so, these are things that, again, people may miss the education on it. People may not have accessible, affordable, comprehensive, or they may not have access to accessible, affordable, and comprehensive sexual health care. And in areas of our country where there may not be as many of these services available, it's also really important that individuals feel comfortable talking to their primary care providers about these aspects of their overall general health. And so for me in my career, several times I went to OBGYN visits with women because they had never gone. Or here's something else that that I've experienced also in my career: women or men who have been sexually victimized or traumatized may have an aversion to seeing a physician that is going to, examine those parts of their body that they associate with previous trauma. And so there may be reasons also why people don't address their sexual health, and trauma may be one of them. And so it's really important that when we're learning about an individual's adverse life events, and I say it like that because not everybody recognizes a traumatic event as a traumatic event. When we talk about things like those adverse events, that we do also specifically ask about any kind of sexual traumas. And again, living and working and thriving, hopefully, in an environment that affirms and promotes sexual health. So as providers, obviously for us, that means being inquisitive, that means being accepting, that means reassuring individuals and treating them with respect and dignity, which I know that you all do. But it's also important that we're aware of this and we look out for behaviors to the contrary in other providers. I had an experience once in which I was interviewing an individual who was referred to the supportive housing program that I worked in. And when I went to the hospital, I read the individual's chart and I got an idea of, what the person's needs were and all that kind of stuff. And then I met with her and we had a great interview, and the person had some hesitancies. They were a little discharge hesitant. But we could work with that. And I thought if I continued to visit her, that we would be able to develop a rapport. And maybe I could at least get her to come and see this great apartment that I had set aside for her. And after I met with the individual, I met with their treatment team. And the psychologist told me that there was nothing wrong with the individual, that they were quote unquote a sexual deviant. And when I asked for information about what that meant, the psychiatrist said, well, you know that he's a man. And I said, well, she asked me to call her by her female name, her chosen name, and refer to her as the gender she identifies with. And in order to form, and first of all, I don't have disagreement. And I think it would be contraindicated to challenge the individual when what I'm trying to do is develop a therapeutic rapport with them. And this individual, again, a psychiatrist, was adamant that the root of all this individual's problems was in what that person saw as sexual deviance. And unfortunately, they pulled the referral because we were at a kind of stalemate in saying, we are going to affirm this person's gender identity. We are going to treat the person with respect and dignity and provide that affirming and welcoming and supportive environment. And unfortunately, that doctor disagreed with that, and the person didn't come to our program. And so, you know, I called it out. It didn't make a difference, but it needed to be called out. Luckily, that psychiatrist is no longer affiliated with the facility, but you know, these are the things that unfortunately sometimes we can run into with our best intentions in community services. So let me just take a sip here because I'm getting a little froggy. Let's talk a little bit about gender. And so, you know, one of the reasons why I'm giving such explicit definitions is that so that you can also use this with other individuals, so that you could use it with your participants in your program if you need to, that you can use it to educate other folks. I'm assuming that because you're here, you're interested and you're supportive of this topic and you see the value in it in terms of incorporating it into the psychiatric services that we all provide. But also I hope that you'll be advocates at the same time. So when we talk about gender, excuse me one second, I just want to take a step back from it. Okay. When we talk about gender, it typically refers to either of the two sexes. So historically, you know, we have been, I'm going to say conditioned, but we have been told that there are two genders, right? And that those are male and female. But one of the things that I say we've become hip to over the years is that gender is a socially constructed idea, right? So it has to do with the social and cultural differences that are associated with male or female gender, and not necessarily the biological ones. Biological sex is, you know, something that an individual is born with. But also that doesn't mean that the person's gender is necessarily in alignment with those biologically sexual parts that the individual is born with, right? So it is also used more broadly to talk about a range of identities that don't even necessarily correspond to these established ideas of male and female. And so, you know, again, like, I don't know, how about thinking of male or female, or if you can give me a couple of examples of social ideas around what it means to be male or what it means to be female. Just drop that in the chat. And I don't want you to think that that's what I think you believe, but these kind of like general social assumptions that we have. Like one of the things that I think of is, and a lot of times I think about it in emotional terms, you know, this notion that men are emotionally strong, that it's not okay for them to be emotionally vulnerable, and they can tough anything out. I know simply that is not true, right? And, you know, this notion that women are more sensitive, that women just are overall more sensitive to their emotions and to the emotions of other people. again, an assumption because I've met a lot of women who are not. And so like those are kind of these social concepts, these social constructs that we have constructed over many, many years. Another is that men, or the male gender, should be the ones out there working and being the breadwinners. And females, the female gender, should be the ones that are taking care of the home and taking care of the children, right? So these are those social constructs and are not at all necessarily related to biology. Great, Sarah. Yeah, absolutely. So like very similar to some of the things that I said. So like, this strong, they're not emotional, they're more cold, they're stoic and logical, right? And constructs of women, they all want children. They're all emotional, or they are emotional, when in fact every single human being is emotional, right? So what does that even mean? We all have emotions. They just may be expressed differently, and they are weaker physically and mentally. Yeah, absolutely. And I just saw well, no, never mind, I'm not going to get into politics. Let me pull myself back a little bit. So it's just a comment that was made by a presidential candidate that expressed that notion. So yeah, these ideas are created. They're created, simply created. And so I think that one of the things that as a practitioner in the field of mental health, that often frustrates me about folks that stigmatize people who are do not identify with their sex assigned at birth, is that this is all kind of created. And so we were holding people up to these kind of imaginary, and I don't want to say imaginary, because we have reinforced these social and gender roles throughout the years, and kind of we've all been a bit conditioned into this, but that we are holding up to people to standards that society has kind of created that really are not rooted in science. And so we should go where the science goes. And one of the things that we do know is that by affirming people's gender identity, by affirming people's affectional status or affectional orientation, we reduce the likelihood of suicide. We reduce episodes of depression. We help to instill confidence in individuals and acceptance of their own selves, their own authentic selves, and that can only be good. And so we should remind ourselves of that. And I'm not saying you need to preach, but remind others of that as well. So gender identity is an individual's personal sense of being aligned with a particular gender, right? So it may be male, it may be female, it may be non-binary. They may not necessarily conform to a specific gender. And there are others, but for today, we're going to talk about male, female, non-binary. And the definition of transgender is when an individual's gender identity, so that personal sense of having a particular gender, is not fully aligned with the individual's assigned sex at birth. So their biological expression of sex. So what the doctor sees when he does the initial examination. Also, please remember, and I've been watching several specials or documentaries on this lately because it's something that has fascinated me, and I wonder, my inquisitive nature prompts me to wonder like how individuals who are born intersexed kind of develop and find their personal sense of gender as well. And intersexed is when individuals are born with both male and female, or components or parts of male and female reproductive or sexual organs. And so, that is also a possibility for individuals. And unfortunately, back in the 70s when I was born, and I'm sure probably unfortunately may continue to happen today, when individuals are born as intersexed and they have this kind of mixed expression of sexual organs or, reproductive organs, very often the parents are making the decision about surgery at a very young age and making the decision about raising the child as a particular gender that the parents choose. And so, this can create, as you might imagine, a lot of difficulty as the individual develops. So, not to throw another thing out there at you, but that is also something else that can occur in individuals. It's a rare condition, but it does happen. We used to call it hermaphrodism, but is now called being intersex. So we've talked about gender, we've talked about gender identity. Now let's just touch really on this basic concept of something called gender expression. Gender expression is how one chooses to present themselves to others, right? So when I like to wear jeans, I wear guys sneakers for no other reason other than I have really big, wide feet and they fit more comfortably for me. But I like to wear men's sweatshirts and I like to, and so it's that way that we choose to express ourselves. It doesn't necessarily align with our gender identity. It's how we choose to express ourselves. It may not. But again, we cannot assume based on an individual's gender expression, right? So, there are individuals who like to dress in women's clothing when they identify gender-wise as a male, right? There may be different reasons why individuals express themselves and how they express themselves. It doesn't necessarily have a direct reflection on their gender identity. Most often it is in alignment with one's gender identity, but not always. And so it's really, we cannot assume based on that. But again, individuals, make assumptions based on the sight of someone. And so this is something that we need to keep in mind. I worked with a woman, she identified as female. She's now passed away, but she was in a same-sex relationship, and she would often dress very masculine and had very, very short hair and found herself sometimes being confused with a male, and that angered her, and she would get very, very, very upset at that. And she came to me crying and asking why that was, and we had a conversation about her style of dress, which is perfectly fine. Was perfectly fine for her to express herself the way she was expressing herself. At the same time, she wasn't understanding how people could become confused, right? And so it was part of like me with her, kind of talking to her about people aren't doing this intentionally. These are confused, it's confusing to individuals, and they are trying their best to make an assumption based on what they're seeing in front of them, right? Based on your presentation. And so she came to terms with the fact that sometimes people are going to misgender her. Sometimes people are going to make mistakes. And she was able to get to a point where she realized it wasn't intentional. It was sometimes still hurtful, but it also wasn't intentional, right? And she got comfortable enough to be able to have conversations with people to say, oh, I'm actually a woman, yeah, this is how I like to dress. It's comfortable, it's whatever. But it took a lot to build her up to the point where she was able to have those conversations with individuals. So that is gender expression. So gender expression is how the person expresses themselves, and gender presentation is how the world sees the individual. And so what I was just saying about Angie, the lady that I worked with, her presentation to the world, the way the world perceived her was, that's a guy, right? Because we make these automatic assumptions based on type of clothes, right? We make automatic assumptions all day, every day about things that we really need to make automatic assumptions about, where it comes to safety and that kind of thing, self-preservation. But our mind also does this all day with other things. And it's a challenge to intervene there. And so people should understand that the world is going to perceive them in a certain way based on what the world, the collective world, understands as presentation that is typically or generally aligned with a specific gender. And so it's viewed through the societal lens of social roles, and specifically these gender roles and the established norms of a culture. So when my mother went to school, she graduated high school in 1972, she wasn't allowed to wear jeans in her high school or at all through her schooling until her senior year of high school. And they were finally, women were allowed to wear pants her senior year. And she said she wore jeans every single day to school that year because she was so excited to actually be able to wear something she felt comfortable in and that felt affirming to her and made her feel comfortable. And so, you know, at that time, it was out of the norm to see women in pants or to see women, you know, dressing in what society views as typical male attire, right? And so we've gone through these shifts at many times in our history. And so I think that we're continuing to go through that shift right now as it comes to the world and society in general, understanding that the way that we perceive people isn't always healthy and isn't always affirming to individuals. And I think at some point the world will get used to it. We'll get comfortable and hopefully we'll be able to treat everybody in an affirming and supportive way. So I just want to familiarize you, and again, you may be familiar with this, but so that you have it and that you can educate others, some common gender identity terms that you may see used or that your individuals that you work with may use in discussing with you their sexual health are things like cisgender. I do a lot of education around this term, and that is that one's gender is aligned with their biological or assigned sex at birth. It's also challenging for me to say biological sex because there are some biological differences that are expressed in terms of it that are associated with gender identity. And so I'm of the born this way persuasion. And so that I think that they're, you know, a person is their person from birth, right? And so it very often people who have a misalignment between their gender identity and their assigned sex at birth had those feelings and had that recognition from very early on in their lifespan. And so, you know, they may not have been able to call it what it was when they were first starting to experience it, but reflecting back, you know, folks can see where they experience challenges and stuff growing up because of this misalignment. And so I like to just refer to assigned sex at birth and kind of not talk too much about the biology of it because I kind of feel like, again, it's with us from the beginning. Non-binary, so that refers to individuals that are outside of the confines of the male-female gender. So individuals who may not identify with either or may identify as both, may also identify as not necessarily either, right? So there are a lot of terms, there are a lot of definitions that I could go over. We'd be here a really long time, but I just kind of want to introduce a few. And then transgender. So again, you know, we earlier mentioned that this is when an individual's gender identity is not aligned with their assigned sex at birth. And something that I included because we don't have a huge Native or Indigenous population here in New Jersey, but I am aware that in the Pacific Northwest, folks, you know, this is a much more prevalent population that you may be serving. And so there is this other terminology that is used within Native American culture, something called two-spirit. And you see this reflected in other cultures as well, that they have, in some other cultures, I think in some Asian cultures, there is this idea, this concept of, this two-spirit, where they're actually, it's a separate gender as they understand gender roles. And in many cultures, this is a revered gender. They are seen as possessing special, I don't necessarily say special powers, but being wiser and having, qualities that neither of the other two genders alone have, right? And so it's also important to understand some of the cultural context within which some of these terminologies develop or concepts develop. So two-spirit, or sometimes referred to as 2S, is something that has a concept that is developed out of Native culture here in the Americas and is culturally considered a third distinct gender. And so if you hear this terminology by any of the individuals you serve, hopefully you will be able to use that information. So affectional orientation. Now, affectional orientation is a newer term for sexual orientation, and it comes from the notion that sexual orientation doesn't quite cover why we desire other individuals as intimate partners or romantic partners. It is more, our desire comes out of our feelings and our thoughts about another person, and that it's not just about sex. Maybe sometimes it is, but for most people, it is not just about, that sexual act. This affectional orientation is more aligned with romantic, or I think it's more consistent with the terminology of a romantic orientation, because it doesn't only involve sex, it also involves the thoughts that comes along with that desire for another person. So one's orientation is defined by whom one is predisposed to fall in love with. Sexual attraction is only one part of that affectional orientation dynamic, if that makes sense. And some affectional orientation terms, probably everybody knows straight, gay, lesbian, right? And the textbook terminology for that is heterosexual and homosexual, and not really anybody uses those terms anymore. Bisexual, and other things that are a little bit more challenging for folks to understand. Terminology like pansexual. So an individual who is sexually attracted to others, and it's not based on their gender identity or how they express the other individual's way that they express themselves gender-wise, right? So this person can find themselves attracted to a male, a female, a trans male, a trans female, or I should say a cisgender male, a cisgender female, a transgender male or female, and maybe somebody who's non-binary. So that is pansexual, that attraction to, more of that, variety of gender identities. Asexual, there are individuals for whom a sexual act is not a part of their life for numerous reasons. It may be based in, medical problems. It may be based in trauma. It may be a choice to be celibate, and a choice that, we should respect as much as we respect, other forms of sexual orientation or lack thereof. And polyamory. And so, this is people who develop multiple kind of loving relationships with multiple individuals, sometimes confined to, one gender identity or expression, and sometimes not. So what is our role in helping people with their sexual health? Obviously we want to be inquisitive just like we are with other aspects of an individual's life. I do know that talking about sexual health can be more challenging. There are certain conversations that we just have not been experienced at having in our culture as much as we have had in asking people other things. But when you really think about it, we ask people sometimes really difficult questions. We ask folks if they've ever experienced trauma. We ask folks have they been abused. We ask folks if they're using drugs or alcohol. We ask folks, have they ever thought of harming themselves? We ask folks a lot of things that are intrusive because, in some senses we need to gather this information. And so, this is another area that we kind of have to get used to through practice and repetition and education to ask questions about. We need to identify unmet needs. So if individuals have needs in the area of sexual health, we have to be able to help them with establishing some goals around it, educating or linking them to services, and always, always, always advocating. So I want to kind of transition over to talking about a tool that we can utilize when having conversations with individuals around sexual health. And you see a picture here on the left hand of your screen, which is a toolkit. It's a training toolkit. You can use it for yourself to kind of self-train, and you can also use it in a group format with coworkers or subordinate staff that you may be responsible for training. But it's a toolkit for using motivational interviewing in having conversations around sexual health and the promotion of positive sexual health behavior change. So one of the ways that we need to start any conversation in which we're hoping to support an individual around needs that they may have that are unmet is to start always with open-ended questions. And so it's something that we call, well, let me back up. It's to start with a format of questioning called OARS. And that stands for open-ended questions, affirmations, reflective listening, and summarizing. And so when we have an individual, that we want to gather a little bit more information about, like maybe about their gender identity, maybe we suspect that the individual may be struggling with something in the area or within that domain of sexual health in their life. Excuse me. We could ask open-ended questions, things like, how would you describe yourself in terms of being masculine or feminine? Right? You're not asking the person, do you think of yourself as a male or a female or neither or both, right? We're not asking that. We're asking them to tell us how they think about themselves and how they identify. Something like, tell me about the type of people that you're attracted to, right? Tell me a little bit about how you keep yourself safe when you're sexually active with another person. So if we ask them, do you practice safe sex? That's really easy to get out of, and to shut the questioning down with, yeah, of course, right? Now, they could lie to you when they tell you about how they're keeping themselves safe, or they may choose not to answer that question, and that's okay too. But, if this is an area that you're trying to address with an individual, or if they expressed or have kind of led you to believe that they may have some needs in this area, you want to get them talking. You want them to provide you with the answers rather than you giving them like canned yes or no kind of questions. And affirmation. So this is your opportunity to identify strengths that the person tells you and reflect that back to the individual. So if you maybe have some concerns about promiscuity in an individual where they're not, utilizing safer sex practices, and they've told you perhaps, well, sometimes I use condoms, other times I don't, sometimes I do, really amping up and saying that is awesome that, you do pause to consider your safety in sexual relationships at times. That's really great that you've done that. And, kind of moving on and trying to motivate them then to do that more, and asking them, like, how do you feel when you take control of protecting your own health? That's really, really, you know, um, affirming in terms of your ability to care for yourself and to take charge of your own physical health. And so affirming any strength, any positives that you see coming out of the conversation. Engaging in reflective listening. So when an individual says something like, you know, yeah, we use protection sometimes, but my boyfriend or my girlfriend doesn't really enjoy sex as much when we use condoms. So I don't know. I just do whatever he or she wants, right? Because I don't want to disappoint them. Reflecting back to the individual. So if I'm hearing you correctly, it sounds to me like you're not using safer sex practices because you're worried about hurting the other person's feelings. And the person can then say, no, that's not at all what I meant, and correct you, which is completely fine. Um, on the other hand, it may show them that you're really, really paying attention to what they're saying. Either way, it's going to show that you're paying attention to what they're saying. It may affirm to them that you really heard them and you understand it, or it may also give them the opportunity to correct your wrong interpretation. And so we always want to use reflective listening to course correct for ourselves and also to show the person that I'm hearing you and this is how I understand it. And summarizing. So summarizing, you don't want to give a whole paragraph on what you heard or to recount everything that the individual told you, but it's a succinct reflection of the conversation. So, for an individual who may have said to you, yeah, I would describe myself as being more feminine, but I'm really not sure. I'm not always comfortable in expressing myself that way, or I wanted to explore, uh, a different gender identity, but I'm afraid, that ability to be able to, pick up on the key points that the person is making and being able to reflect that back to them to show that you're kind of getting the gist. And again, similar to reflective listening, to allow them to course correct you before moving forward. Summarizing is really great when you're coming to an end of the conversation, when you may be, wrapping up a visit with a person, a session with a person, before you move on to action steps, right? Because you both want to be on the same page with what the individual's responsibilities may be in following up on some goals and what your responsibilities are in terms of assisting them. All right. So let's directly apply motivational interventions by stages of change. So for any of you who have not attended trainings on stages of change, um, this is a way of understanding where an individual is in terms of making behavioral changes, desirable behavioral changes. So very often, this is applied to health related changes like smoking cessation, exercise, weight control, or changes in diet, um, sexual health as well. Um, but motivational interviewing can be utilized in almost any kind of counseling or um, uh, social service interaction where the desire is to support the person to make healthy changes. And so using the example of someone who may be not utilizing safe sex practices, the individual who is in what is called a pre-contemplation stage, that means they're not aware that this thing that you and maybe others see as a problem, or maybe they've even expressed some challenges with as consequences to the problematic behavior, they're not recognizing where the root problem in the behavior is. So it's not on their radar. It doesn't mean that they're resistant. It doesn't mean that they're being defiant, that they want to ignore this problem. They may truly not recognize it as an issue that they need or should change. And so at this point, the person's not even considering change and they're unaware of the negative consequences. Maybe they haven't connected the dots yet, right? So this may be an individual who's sexually active with multiple partners, unaware of health risks and their own sexual health status. Maybe they've never had an STI or STD check. Maybe they've never gone to an OBGYN and had that pelvic exam, right? The intervention at this point is not action. Linking them to someone, linking them to a sexual health provider is probably not going to be effective. They may not show up for that appointment because they are unaware that there is a problem. They're unaware that there could be these negative consequences, or they may already be suffering or experiencing negative consequences from that choice not to use prophylaxis. So the intervention at this point is just to provide information on the current behavior that as you're seeing it and any negative consequences that are being seen. You can also provide information on what it means to use safe sex practices, what that looks like, for a man, for a woman, and how to have those conversations. But it's not the time at this point to make the linkage and to go full steam ahead with, making that behavior change because the person isn't quite aware of it yet. Then we have contemplation, and that is where the individual is aware of some of the pros, because there's sometimes pros in the current behavior, and cons of that current behavior or feelings, but they're not yet ready to take action, right? So think about the individual who smokes cigarettes. We all know that smoking is not good for our health, right? Yet so many of us continue to do it. And so many think about quitting or may have quit at some point in time and, only to start smoking again. And so this idea of contemplation is a thing where a lot of people are in contemplation mode around a lot of health behaviors. I'll start that diet tomorrow. I'll start exercising this weekend. I'm going to reduce my work hours. I'm going to create better boundaries between my work life and my personal life, right? There's a lot of things that we all think about. And so it's not just the individuals that we serve that can kind of live in this area of contemplation. And so during contemplation, an individual can identify pros and cons of unprotected sex, but they're not ready to make a change. So when we talk about the pros of a potentially, problematic behavior, we talk about the things that kind of keep them doing it, keep them engaged in it, right? So for somebody who smokes and they realize, they start to put a connection of, well, when I smoke, I go outside and it's really nice to be outside. And I get to look at nature and I feel calm, right? And sometimes people connect that sense of calm with the act of smoking itself, when there may be these other things that are also helping to reinforce that behavior. Well, you get out of your house, you go outside, or you smoke with other people, and there's that social component to it. And so for an individual in this situation, they may feel that they are more intimate with their partner, that they have a deeper connection if they're not using protection, right? So that might be something that may be reinforcing this behavior, or that it simply keeps their partner happy, right? And, people want to keep their partners happy. And so they're aware of these pros and cons. However, they're not prepared to make that change. At this point, what we want to do is we want to amplify ambivalence. So, for this individual, let's say that they have a child and they're still kind of engaging in risky behavior. We can say things like, oh, I know your child is really important to her. And you talk about, wanting to see her grow up and do big things. And, any kind of risky behavior can impact your health. You don't necessarily have to point out the sexual behavior, but just that any risk taking can potentially impact your ability to be there for your child. So kind of amplifying that distortion in the person's thinking. Preparation. An individual has decided to take action and is making a plan to do so. So this might look like the individual has decided to get an STD test and to use protection at least until the test results come back, right? So this notion that I'm going to get tested, when it comes back clean, I'm going to go back to that other behavior again. So, okay, we can work with that. What we want to do as the intervention is to strengthen that commitment. to really rally behind the person, to identify options, to identify where they can go to get that test, to support the plan, to provide transportation if it's needed, to help connect them, to advocate for them, and to hopefully rally around them enough that they continue that positive behavior change moving forward. Action. So in the action phase, the individual is currently addressing the plan or the problem, which might include seeing specialists, attending a group, depending on what the problem is. In this situation, we're talking about, risky sexual behavior. And so an example would be an individual who has received sexual health counseling from a clinic or a doctor. They've been tested for STIs, and now they're starting to use protection regularly and hopefully getting tested once or twice a year to make sure that they're still sexually healthy. And we need to acknowledge that that change is really, really hard, especially understanding that, this could have consequences in an individual's relationship with their intimate partner. And so for a person to make that choice to protect their own sexual health, that is something to be celebrated. And it's very important that we support the execution of that plan and help individuals work through, kind of consequences that are sometimes negative, like the loss of a relationship that may stem from them taking care of themselves and putting their own physical health and safety first. And then maintenance. And so maintenance is the stage in which the new behavior is established and maintained. So the person gets tested regularly for STIs, they're using protection, and they've incorporated the practice with their current, future potential sexual partners. So in this situation, we don't want to just forget that we made this behavioral change. We want to check in every once in a while, make sure that they have the supplies that they need, that they still feel motivated to continue this behavior change and to sustain it, and to, consistently reflect to them how strong they are for being able to make this change and how courageous it was for them. All right. So I did also offer these resources last week, but in case you weren't there, it'll be included in this in the resources list for this webinar as well. These are a few organizations, professional organizations, that also have really nice educational components to their websites. And so I think it's one of the last slides, I included a list of those links to those websites. The American Sexual Health Association, the American Public Health Association, which has a subsection specifically around sexual health, but it also has a lot of great resources for other aspects of overall health and wellness. Centers for Disease Control and Prevention are great, and Sexual Health TV, which I believe comes out of the American Sexual Health Association. So these are training and educational videos that you can watch yourself. You can share them with individuals that you serve, with coworkers, and they really do provide a lot of great kind of cutting edge information, because in the world that we're in right now, I am, again, I am a Generation Xer. And so I feel like very often I am trying to come up to speed with terminology and language that I feel like folks in younger generations, probably a lot of you, are more hip to. And so if you're in the demographic that I'm in, or if you are also just, not as well versed as you would like to be or in sexual health, and specifically around gender identity and affectional orientation, I would say mostly gender identity, this is a great resource to go to, because there's no silly question. And one of the things that I really do want to express to people is be okay with making mistakes. Just like we talk about, we want the individuals we serve to be able to get to a place to be vulnerable and make mistakes. There's this thing that we talk about in psychiatric rehabilitation that is the dignity of risk. And everybody should have the dignity of risk. And that is the risk to make mistakes, right? But to also be open to feedback. So I have presented related webinars on related topics before, and I've made mistakes. And I've had folks correct me. And I love that because it makes how I understand the topic stronger, right? And it prevents me from making that mistake in the future and insulting anybody or offending anybody. And so that's what we want to do. We just want to get closer to proficient and good, right? Okay, so why don't we go ahead and pause there? We have about 10 minutes left, and I just want to open it up for anybody if you have any questions or comments, or if you want to share any experiences that you've had with individuals that you worked with and around gender identity or affectional or sexual orientation and how you've supported them in the process that might help your peers that are also attending today or who may watch at a later time. So if you have anything that you wanted to offer, now is the time. If you have any questions that you want to ask or questions, requests for future trainings, you could also do that as well. So we'll go ahead and take a pause here while I read this screen to you. I appreciate your time, attention, and participation. So today's webinar was hosted by DBHR through the Healthcare Authority. We'd like to remind everyone that the slides, a link to the recording of this session, and a wealth of other resources will be available in a follow-up email. Please don't forget, they especially asked me to express this, do not forget to check out the Foundational Community Supports newsletter for all things FCS and upcoming training events. And if you'd like more information on becoming an FCS provider, you can reach out to AmeriGroup at the number on the screen. Here's my contact information if anybody feels that they would like to contact me. And so that will be included in the handout. And again, here is a reference and resource page. The toolkit that I showed you earlier by Tennille and Borman is listed as this first reference here. And this toolkit is downloadable from the Temple University Collaborative, and the website is listed there, free to use. And free to share with other people. So hopefully you'll be able to download that and make use of that. Okay, and I see no other questions, so we're going to go ahead and wrap up at this point. I want to thank you all for attending. I hope you have a wonderful rest of your week. Happy Friday to you all tomorrow. And we'll be back. Actually, I want to put in a plug. There will be a supportive housing learning community on next Wednesday, the 14th at 9:30 a.m. your time on assertive engagement. And it's really geared towards those individuals in supportive housing services who are kind of at a stalemate, maybe not making a whole lot of progress towards goals, maybe are satisfied with where they're kind of at in just having housing and being out of a hospital or being out of a homeless situation. And so we really hope that we give folks ideas on how they can, continue to engage with individuals when folks don't want to be engaged. And I know from experience that can be a struggle. So hope to see some of you next Wednesday. And if I don't, have a wonderful rest of June. Thank you, everyone.